Okay, continuing on with drugs. Each week we're reviewing one of the classes. Today we're going to do class 1B agents. And just remind everybody that they shorten the action potential. They have relatively little effect on rapid sodium channels at normal heart rates. And since the action potential is shorter in the atrium than the ventricle, the effect is much more profound in the ventricle. And these tend to be use dependent, meaning the faster the heart rate, the more likely that these agents are going to do something. So let's go through each of them. Lidocaine. I would argue that it is still probably the drug of choice for ventricular um, arrhythmias in children. And even though if you look in PALS, of course, we're taught to use amiodarone as a first line, but the truth is that certain disturbances or certain causes of VF, particularly long QT syndrome, which is a much more important cause of ventricular tachycardia in children than it is in adults, constitutes a much higher percentage. That is a that is an arrhythmia that would be where amiodarone would be contraindicated because amiodarone in part works by lengthening the QT interval, as we learned a few weeks ago. So generally speaking, although I would not ever tell you to not follow the teachings of PALS, I would say that it's rare that you're going to get someone's going to have criticism for you for using lidocaine for the treatment of ventricular arrhythmias. It suppresses automatic rhythms and early after depolarizations, and it is eliminated in the liver. And the half-life of the agent is 1 to 4 hours. So very short half-life, which is why it needs to be given as a continuous infusion. Again, it shortens the action potential in ventricular myocytes, suppresses abnormal automaticity. And it's very important that if you have a patient who is in heart block following open heart surgery who's having a ventricular escape rhythm, you want to be careful in terms of giving lidocaine because it could cause asystole by suppressing the escape rhythm. So you would not do that unless you had temporary wires or permanent wires that you were confident were working well. So try to keep that in mind. And lidocaine suppresses, again, after depolarizations, which is an important mechanism for arrhythmia in digoxin toxicity when the levels are too high. It has almost no hemodynamic effect at all, which is good. Could be used in people who have bad heart function. And again, it's almost exclusively used for the treatment of ventricular arrhythmias. Interestingly, it can terminate up to about 15% of SVT. And so I'm not suggesting that this agent should be used for the treatment of SVT. I would not consider it to be first, second, or third line therapy for it, but the fact that somebody in SVT might terminate with lidocaine does not mean that it was not SVT. But again, I would not use this agent for that purpose. Perhaps the most important side effect, which we all need to be very aware of with lidocaine, are the neurological side effects. So the most serious one is seizures, and it can be a little bit idiosyncratic. Some patients at a relatively low dose of lidocaine will have seizures, but it also can cause all kinds of other non-seizure-like neurological symptoms like visual disturbances, paresthesias, slurring of speech, dizziness, perioral numbness, etc. So all of these are possible side effects of lidocaine. So you should be, always be careful with that. In fact, I would argue that almost every older patient who we use lidocaine, almost 100% of the time, they will describe some vague neurological symptoms associated with its use. So you should be careful about that. In terms of interactions, phenobarbital will lower lidocaine levels because of its liver metabolism, And cimetidine not even really available anymore, but propranolol will raise lidocaine levels. So you need to be cognizant of that and dose very conservatively with lidocaine in patients who are already on propranolol. Okay. Mexiletine is sometimes we think about it almost as if it's like oral lidocaine because it's in the same class and it has a similar mechanism for efficacy. It is very well absorbed from the GI tract. Again, like lidocaine, it's metabolized in the liver, and it has a half-life of between 8 and 16 hours. And so, for that reason, it's dosed in a Q8-hour manner. So it's a little bit of an awkward medicine to take because it has to be 3 times a day. Like lidocaine, it shortens the action potential in ventricular myocytes, and again, it can suppress abnormal automaticity, so it should be used sparingly in people who are in heart block unless they have well-functioning wires, and it can suppress after depolarizations. Um, so when is it used? Well, it can suppress ventricular activity. Um, but it's only successful in suppressing inducible arrhythmias in the lab 5 to 10% of the time. So in the old days when people didn't do ablations for VT or when they didn't use amiodarone or there weren't defibrillators, it was common that people would be put on an agent for ventricular arrhythmias and then they would take you back to the cath lab to test to see if the agent was working. But it turns out mexiletine wasn't so good for that. Almost never is it used exclusively as an agent for the treatment of ventricular arrhythmias. Almost always you use it in concert with something else. Dr. Walsh used to say to me, or one of his favorite lines was that mexiletine treats halters but not people. And by that, he meant to imply that it's very common that if you put somebody who has a lot of ventricular ectopy on mexiletine, you will reduce the amount of ectopy they have. But in the case of somebody who has a life-threatening ventricular arrhythmia, his point was it doesn't always reduce the risk of dying suddenly. Probably today, I would say the most common time that we use it in pediatric cardiology is when we use it in conjunction with a beta blocker in some patients who have long QT syndrome, particularly sodium channelopathies, long QT type 3, SCN5A mutations. And the interesting thing is not all SCN5A mutations are responsive to mexiletine. Some are more responsive to flecainide, and there are ways experimentally to determine which of those two agents would be more effective. But practically and clinically, most electrophysiologists, if they have a patient with long QT type 3, will try mexiletine first because it's generally a safer agent, has fewer side effects, and if then say flecainide, and usually it's quite remarkable. You can actually see a substantial shortening in the QT interval with the use of mexiletine. So it does have a very important role for certain very bad long QT type 3 patients who, as you know, typically have longer QT intervals than other forms of long QT syndrome on average, not as a rule. And so you want to have that in your armamentarium, your toolbox. Has no hemodynamic effects. It also can cause tremor, blurred vision, ataxia, and another important point about mexiletine, which I don't have listed here, which is important, is it lowers your seizure threshold just like lidocaine does. And I once took care of a patient who had long QT who was on mexiletine, and as an infant, whenever he would have a fever, relatively low grade, he would seize because the dose of mexiletine was high and it was lowering his seizure threshold. So his family actually had to have a rectal diazepam ready to treat his seizures, which he would have with fevers. They also were aware that aggressive fever management was important, and I would argue that for all people on mexiletine, that would probably be prudent. It can also cause nausea, diarrhea, and vomiting. The levels of mexiletine are lowered by phenobarbital, phenytoin, and rifampin, and levels are raised by INH and chloramphenicol, which we almost never use any longer, but these are some drug interactions that are important. And then just for completeness sake, phenytoin is the last of the 1B antiarrhythmic agents. I would say today in the present era, it's extremely rare to see anybody being treated with phenytoin using phenytoin for treatment of an arrhythmia. This was actually, interestingly, very commonly used in the 1980s. Some of you may be aware of a guy by the name of Paul Gillette. Paul Gillette was probably the first pediatric electrophysiologist at the time. He was working at Texas Children's and really was the only person in the 1970s and 80s who had a lot of interest in pediatric electrophysiology, or was one of very few. And so and most people had no interest in it. So basically, as is often the case, Dr. Gillette would say, if Dr. Gillette said something about the management of arrhythmias, most people listened because he had more interest in it than anybody else. And so he had a strong belief that phenytoin was a good agent for the treatment of ventricular arrhythmias in children. And so for a while, lots of kids with VT or other ventricular arrhythmias were on phenytoin. In the interim 40 years, it's largely been debunked to be a particularly good antiarrhythmic agent for ventricular arrhythmias. I mean, it might be okay. I've never used it in my career. There's always been better agents thought to be better than phenytoin, so we don't really use it very often. Perhaps the only time that we could use it is if somebody had ventricular arrhythmias that were induced by digoxin toxicity, like VT or VF. It's supposed to be reasonably effective for that, and it can be given intravenously. But again, I think most people would probably use lidocaine rather than phenytoin in this circumstance, but there are reports of it being efficacious for that particular indication. All right. Any questions about the 1B agents this week? All right. If not, then we'll move forward to one or two unknowns. Okay. Uh, okay. So this is a tracing from somebody who has a pacemaker. And my question to the audience is this a unipolar pacemaker or a bipolar pacemaker? And can you tell? So I'm going to ask Tony if she has any thoughts on this.
Well, I can see the pacing
So,
spikes,
right. So we agree it's paced.
but I'm not sure if I will be able to tell if this is uni or bipolar.
Okay.
Um, they have different like amplitudes, but I don't know if that's relevant for that. I wouldn't know.
Well, I am actually asking about the amplitude. So remember that whenever we're pacing, the electrons need to go from the one pole to the other, cation to anion. And so all pacing, in a sense, is bipolar. There always has to be two poles. So, for
Mhm.
example, one is the ground, and one of them is the source of the electrical current. And the ground is taking the current. And so when we have a bipolar, so basically there always has to be two poles in all pacing. So the concept of unipolar and bipolar is a little bit of a misnomer. Um, when we say that someone has a bipolar, has bipolar pacing, what they usually mean is that at the tip of the pacemaker wire, there are two electrodes, with one being the cation and the other the anion, the cathode and the anode. And if somebody has unipolar pacing, then they only have one electrode at the ends, and the pacemaker itself is the ground. And so when you have a large distance between the two electrodes, the two poles of the pacing, it creates a much larger artifact on the electrocardiogram than if you are pacing between two electrodes that are literally 2 or 3 millimeters apart. And so, generally speaking, when you see such large pacing spikes as you see on this tracing, it's usually a sign that the patient is being unipolar paced and the reason for this large artifact is that these electrons are traveling not only in the myocardium but through a lot of skeletal muscle all the way over to the area where the pulse generator is. Now, the one uh, caveat or exception to what I'm saying is in the ICU, if you have a patient, if you have an ICU where you have this pacemaker augmentation feature turned on in the ICU. So in our ICU, Dr. Iden likes to turn on this feature that when the device senses a high frequency electrical signal, it will augment it and actually change the color. I think they make it green or something in order, and the theory of this is to make it easier for the bedside staff to see when the patient is being paced. I have always not been a fan of this technique because I think that what happens is people see spikes and they don't necessarily check to see that there's capture. People conflate the presence of a spike with actual electrical capture sometimes. Also, it tends to augment anything that's high frequency, so it can be, I find it can be very confusing. I'd rather it be just the way it is. And I might add that some surgeons will, some surgeons will only put one wire on the heart. And some of the wires, temporary wires that surgeons use, have two poles on them. They're actually bipolar leads. And other surgeons will put two ventricular leads on so that you can pace from one to the other on the ventricle. And always remember that anything can be the ground. So like for example, when I was at Columbia, Dr. Quagabor, when he was still practicing, he felt that it was almost never going to be the case that his post-op patients were going to have heart blocks. So sometimes just so that he could say he put a wire in, he would put a single unipolar wire on the patient's heart, and that would be the only wire the patient had. Now, you can't pace through one wire that is a unipolar lead. So in those cases, if that patient had gone into heart block, one would need to put a skin lead on the patient in order to create a ground for the electricity to go from one to the other. And that was not uncommon by some surgeons. And we can go over, if you're interested at another time, how to put the ground on a patient in the ICU. It's actually fairly straightforward, but not if you've never seen it or done it before. Um, so the bottom line is this is an example of unipolar pacing. And again, all pacing is bipolar. It's just that in this case, the two poles are so far apart that it causes this very large artifact. So when you see a very large artifact like this, it's usually unipolar. Now, we don't actually do unipolar pacing very often anymore. The only cases where we see it, in my experience in the present era, is sometimes some surgeons will put unipolar button electrodes on the heart of small infants because they don't want to put a bipolar lead on because there's only so much real estate on the epicardium of a small baby. Um, and so they sometimes are paced unipolar, although most surgeons have moved to putting bipolar epicardial leads. And the reason that we don't love unipolar leads is, I would say, twofold. First of all, most pacemakers, if you have a problem with one of the connections between the pole and the heart, which, as you know, can happen in any patient, um, the the impedance is going to suddenly change for pacing. And most permanent electronic pacemakers have a feature for emergency that when they notice a very large change in the impedance suddenly, it will automatically start pacing unipolar on the theory that there's evidence that one of the poles is not working. Um, and so if you have a bipolar uh, if you have a bipolar lead, then and one of the pods touching the heart is broken, it's possible that the other will work and that you can emergently switch to unipolar pacing. However, if you have only a unipolar pod and that breaks, then you basically lose capture and have no pacing. And so uh, and it's been shown that when babies have bipolar epicardial pacemaker wires, on average, they last longer than unipolar leads because because of probably in part because they have this backup, meaning that they still can be paced. And I have quite a lot of patients who've had bipolar epicardial leads where a couple of years after surgery, one of the pods seems to be not functioning and they end up being unipolar paced. It's also, by the way, why I get nervous when I see large children who are still living off of unipolar epicardial leads. I just saw a patient from upstate New York last week who the surgeon at age 12 put in unipolar atrial and ventricular leads in someone with chronic heart block. And it was disappointing because now she's like 16. She's close to going to college. Um, and so unipolar leads tend to also, the battery tends to go out faster when you're unipolar pacing. So we were talking about how even though she only had these leads put in epicardially 6 years ago, I'm likely going to change her to a bipolar system because she's pacemaker dependent, and I'm not excited about the stability of a single unipolar epicardial lead. So that's pretty much the story of epicardial versus bipolar for pacing. Any questions about that? Okay. I think then I'm going to stop a little early today. Appreciate your attendance, and I'll see you at Sinai in just a little bit, guys. Have a good day.
Thank you, Dr.
Thank
Pat.
you.
Bye bye now.